Rebecca Ewers is our next presenter. Delighted to introduce her. Rebecca is a clinical nurse specialist in the intensive care unit at Epworth Hospital in Melbourne. She's currently completing her Masters of Nursing by Practice by minor thesis being done at Deakin University, and she's going to be presenting an exploration of the usability of 2 delirium screening tools in Epworth Richmond ICU and the pilot study. So,
thank
over to you.
Thanks, I'm really thrilled to be here. Actually, completed the Masters now, it's all finished, and I'm just thrilled that it's actually gotten me to Adelaide, to the conference, so I'm presenting what I was studying. So delirium has become a really hot topic these days. Everybody's really on to the delirium screening. And this is because the Australian Commission for Safety and Quality in Healthcare brought that into their clinical care standards back in 2016. So delirium screening is really nothing new. The first ICU-specific delirium screening tools were published in 2001, and we are only just finally getting onto the ball. So, okay, I'm a little bit nervous. So our hospital responded to these new clinical care standards and decided that they were going to introduce delirium screening. They were going to introduce the 4AT, which is the rapid clinical test for delirium, and this was going to be implemented in all areas, including ICU. And that brought about quite a few questions because it's not an ICU-validated screening tool. So I got thinking, I thought, why can we not use validated tools for ICU? Will these tools detect more delirium than we're already detecting already? Do we actually have a lot of delirium? Because we're coming from the perspective of a private hospital with a really large cohort of elective surgical patients. So very different to what's in the literature at the moment. And how are the nurses going to respond to this? So it looks very busy. These are the 2 tools that we used. A lot of people might be familiar with the KMICU. I think this is the most popular one at the moment, and it's a flow chart over on the left, on the right, left, right. And then the checklist here, it just has 8 features or 8 categories, and you score 1 for each category that a feature might be present in your patient. So a score of 4 or more would indicate delirium. So these are the 2 that we use to compare. So we used multiple methods methodology. We had 3 phases. We had a patient assessment phase with nurses from that were working at the bedside. We had a medical record audit, and then we finished it off with focus group interviews. So the aim for our patient assessment was just to evaluate these screening tools as they're used by bedside nurses during routine care. So we had 10 amazing volunteer nurses that were educated to the CAM and the checklist. So I'm just going to refer to it as the checklist because intensive care delirium screening checklist takes a long time to say. So they use these tools just on their already allocated patients during normal care. The medical record audit, we wanted to compare the predictive accuracy of the 2 screening tools against a medical diagnosis of delirium. So we collected this data from the medical ICU discharge summary, which should reflect any new diagnoses that happened to the patient during their admission in ICU. So delirium should be documented on this. So we had 99 assessments on 66 individual patients, and almost 17% had delirium documented as a medical diagnosis on their discharge summary. And almost 26% actually had a positive screening result at any time on either of the tools. So it's important to point that there were 2 discharge summaries that were missing for patients that did screen positive with our tools. and there were also 2 patients for where delirium was documented on the ICU discharge summary, but it was not picked up by either of the tools, and this could be due to the fluctuating nature of delirium. And also, we weren't continuously assessing our patients. It was more of a convenience sample. So we compared each tool against the discharge summary to assess its predictive accuracy using receiver operating characteristics. Unfortunately, we couldn't find like a statistical difference between the tools. However, we can see that the CAM ICU had a slightly more specificity, and then the checklist was more sensitive. So, our focus group interviews. These were just to understand the differences between 2 delirium screening tools as perceived by the nurses, and we also wanted to understand ICU staff perceptions of delirium, the prevention for its screening and management currently being used. So these took 30 to 45 minutes. They were semi-structured, and we had 14 participants in total. So the difference here is the first focus group consisted of the ICU Leadership Team. So we invited all senior nurses, ANUMs, educators and medical staff to attend this focus group. And we actually had a good turnout of 4, and most of them were actually medical staff. And then the remaining focus groups were just the nurse assessors that used the tools. So right off the bat, it was really evident that there were divergent views between the first focus group and the remaining 3 focus groups as to the benefit of delirium screening. So focus group 1 members felt that delirium was more of a path of a course, and that screening for it was not really going to add to current management. They felt that it's already observed by the bedside nurses and that it wasn't really going to change a lot of outcomes. On the converse, our nurses actually did find a lot of use in the tools, and if it wasn't just to identify delirium, it was mainly useful as a communication tool. So they found it was very helpful to have rock-solid evidence that they could present to the doctors and say, this result is through, this is delirium, and it was helpful to escalate patient care based on that piece of paper. They also found it was important, the delirium screening, introducing that into the unit would raise awareness as well of the importance of delirium and managing that a little bit better. So there are really mixed opinions for each tool according to the nurses that use them, and there's no spoilers here, there was no clear favourite. So here some people felt that the CAM ICU was much quicker to complete than the checklist, whereas others thought that it was quite awkward to use. They felt it wasn't natural. They had to read off a piece of paper as they were assessing their patients at the bedside. Whereas the checklist, some people felt that it gave them a little deeper understanding to the delirium state of their patient. As a checklist, it uses objective data. So some participants were concerned that it relied heavily on some aspects of a handover from the previous nurse. So if the nurse hadn't paid attention to the delirium state of that patient, then this information wouldn't be handed on and they wouldn't be able to use the tool appropriately. So in conclusion, we said that either screening tool is feasible and that nurses do find the tools useful, particularly to communicate with their medical staff, and that all medical staff really need to be included in any implementation to get them on board.
very topical area. Thank you for your presentation. I always find that the recurrent theme about communication and really being listened to from the nursing point of view over to the medical staff is critical. So I was surprised but not surprised to see it again turn up in your presentation. So that's my little chair prerogative. But open to questions. We should keep it interactive with you. Does anyone have any questions for Rebecca?
I've just got a comment really, and I share the views of many of those nurses, and I think one thing, just as you take this forward, I hope you do, is that it's what you do with that information, because I personally get a little frustrated because you identify delirium and document it and maybe talk about it on the round, and our medical colleagues go, well, yes, of course they're delirious, and you're going, well, maybe we should just go through some of the factors that might be contributing. What can we do to? But there isn't that. So some of the problem with implementing it is like, well, why should I write this down if no one's really going to take much notice of it? And it's a difficult one, but.
It is difficult, and I think the views from a lot of our nurses was that they're sitting at the bedside, they know this patient is delirious, and due to its fluctuating nature, of course, when a doctor walks in, they're actually having a lucid moment, and they wonder what the bedside nurse is talking about, and that was really frustrating, like that was really evident, so hopefully this will help.
Okay, thanks, Rebecca.
Thanks
for sharing your results today.